Good evening, everyone, and welcome. I'm Kristi Epstein, and I'm the nurse practitioner in the MS clinic. Some of you may have met me already. I would like to welcome you to our first ever session of our new virtual education series for people who are affected by MS. If you're here tonight, it means that you're either living with MS or you care about someone who is affected by MS. If you're here, we welcome you, whatever the reason for joining us today. We are so glad that you're here. We hope that this series of webinars will be informational and helpful as you manage and flourish with this disease in your daily life. So I'm going to go over a few housekeeping items for you during the webinar. You will remain muted and your cameras will be turned off during the event. The session will be closed captioned and recorded for viewing at a later time. As you listen to the presentations, please feel free to type in any questions that you have into the Q&A box. Just remember not to enter any personal details. Enter general questions that you would like to have answered. At the end of our session, the expert panel will have plenty of time to answer your Q&A questions. I will serve as the moderator for tonight's conversation. I'm a nurse practitioner and I am specializing in multiple sclerosis. I have lots of experience as a clinical nurse, over 20 years, including critical care with special certification, infusion therapy, oncology, and of course, neurology. My special interests in the MS clinic include wellness, reproductive health and issues, and clinical research. With me tonight, we have the members of our team at the Ohio State Wexner Medical Center. That includes our director, Dr. Benjamin Seagal, Dr. Margaret Hansen, Dr. Turisham Gyang, Dr. Robert Follis, and Grace Schaffner from the Physical Therapy Department. We'll learn more about each of our presenters as we proceed through the evening tonight. Without further delay, I'd like to start with a couple of questions for you. On your screen, you can interact with our poll question by selecting an answer and clicking submit. Let's read our first question. Which of the following statements do you think is correct? Go ahead and select your answer. We'll give you plenty of time to answer before we move on. Remember to click submit so that your answer can be registered. Excellent, thank you for participating. Looks like we have really good response, and the majority of you feel that people with MS are no more likely to get infected by COVID-19 than the general population. All right, let's move on and try one more. Which of the following statements do you think is correct? People with MS are more likely to develop severe complications from COVID-19 infections, or people with MS are no more likely to develop more severe complications from COVID-19 infection than the general population. Let's see what you think. Go ahead and submit your answers. Remember to click the submit button. Excellent, great job, everyone. So it looks like we're kind of divided. We're about 50-50 on the answer to this question. That's excellent because our first speaker, Dr. Seagal, is going to give an excellent speech on this topic. So it is my distinct pleasure to introduce our first speaker, Dr. Benjamin Seagal. He will be talking about multiple sclerosis and COVID-19. Dr. Benjamin Seagal is the chair of the Department of Neurology, and he is director of the Multiple Sclerosis Center at The Ohio State University, Wexner Medical Center. He is an internationally respected thought leader in MS, having published over 100 original research articles in high-impact journals. His research is supported by annual funding from the NIH in excess of $1.3 million. Dr. Seagal has been featured on Best Doctors in America list each year since 2010. He has received multiple research awards, including the Harry Weaver Neuroscience Scholar Award from the National Multiple Sclerosis Society. Dr. Seagal is the director of the Americas Committee for Teaching and Research in MS, ACTRIMS, the largest academic organization in North America. This September, he organized the MS Virtual 2020 conference, a global conference on cutting-edge research in MS that was attended by over 10,000 MS physicians, scientists, and trainees. It is my pleasure to introduce our director, Dr. Benjamin Seagal.
Well, thank you very much, Kristi, for that kind introduction. It's a pleasure to speak to all of you today and to introduce myself as well as the rest of the MS team at Ohio State. For those of you who don't know me, I'm a fairly recent transplant to Columbus, Ohio, having moved here 17 months ago to become the chairperson of neurology, the director of the MS Center, and director of the Neuroscience Research Institute at The Ohio State University. And I'll tell you, it's been something of a whirlwind over the last 17 months. Most of it has been very positive, a great trajectory forward, though we have had to contend with the pandemic. Despite the pandemic, we have recruited 17 new faculty members, new doctors to the Department of Neurology, and we have offer letters out to many more. We anticipate doubling the faculty over the next 3 to 4 years. And 3 of our new doctors are MS specialists. You'll be meeting Dr. Terasham Gyang a little later on this evening. We were lucky enough to recruit her from Florida, and she joined us in October. And then we have 2 more additional new MS doctors who will be joining us in September, one from Johns Hopkins and the other from Mount Sinai in New York City. We have a burgeoning research portfolio, and I'm excited to tell you a little bit about that. That includes new clinical trials, particularly in progressive MS, which is an interest of our center, as well as new research into how to stimulate growth or regrowth of the myelin sheath. And some of you may have heard of our latest research discovery on the news or on the radio. We've discovered a new type of inflammatory cell that actually stimulates repair in the nervous system as opposed to causes damage. And we're right now testing whether this new cell therapy is beneficial in an animal model of MS. We have a multidisciplinary clinic approach with specialized physical therapists, speech therapists, pharmacists, and collaborators in urology and neuro-ophthalmology. So we now have a really first-class comprehensive MS center with these new doctors joining myself, as well as Dr. Robert Follis, who's been a standard bearer in our MS clinic. So now I'd like to begin discussing the topic at hand, and that is multiple sclerosis and COVID-19. Next slide, please. I'd like to provide some introductory remarks about the COVID-19 virus itself. Now, COVID-19 is a contagious respiratory illness caused by infection with a new coronavirus called severe acute respiratory syndrome coronavirus 2, COVID-19 for short. COVID-19 appears to spread more easily than the flu. It can also take longer for individuals who are infected with the virus to develop symptoms, and people can be contagious for longer periods of time. COVID-19 spreads through a variety of routes, but most commonly through aerosolized particles that are released into the air when we speak, when we cough, when we laugh, and even when we breathe. And people who are within 6 feet of someone with the infection can be exposed and develop an infection him or herself. It's unknown how frequently the virus is transmitted via contaminated surfaces. New slide, please. People of any age can get COVID-19, including healthy young adults and children. However, people who are older or who have underlying medical conditions such as chronic heart, lung, or kidney disease, obesity, type 2 diabetes, sickle cell disease, or people who smoke are at higher risk for developing severe complications of COVID-19 infection that may require hospitalization and even admission to the intensive care unit. People with COVID-19 have a wide range of symptoms, and the disease could also vary widely in severity. Symptoms generally appear 2 to 14 days following exposure. A significant number of patients who have recovered from the acute illness complain of lingering symptoms, and many of these involve the nervous system, including headache, difficulty concentrating, difficulty with short-term memory, as well as low-grade fever, muscle weakness, and breathlessness. Next slide, please. So the symptoms that people experience with COVID-19 overlap a good deal with the symptoms of people who have flu or even the common cold. And these symptoms include fever and chills, cough, shortness of breath, fatigue, muscle aches, headache. One symptom or symptom complex that is more common in COVID-19 than in many other infections is a loss of smell and taste. People could also experience sore throats, congestion or a runny nose, and less commonly, GI upset, diarrhea, nausea, and vomiting. Next slide, please. So what about people with MS? You know, when we see patients in the MS clinic, many have had concerns about their vulnerability to the pandemic. And I have often been asked, am I more likely to become infected with the COVID virus because I have MS? If I do become infected, am I more likely to experience a severe course of the infection? And, you know, this audience answered the question about increased incidence during the poll, and a number of you indicated that you didn't think people with MS were more likely to become infected with COVID-19. And actually, the recent data backs you up. So in September, I chaired a global MS meeting, as Kristi mentioned, and we had a special session devoted to COVID-19 in MS. And investigators shared data with us from multiple centers throughout the world, North America, Europe, Australia, and from multiple registries. Now, registries are databases in which people with MS or doctors who treat people with MS send in reports about different characteristics of MS and people's experience with the disease. And from multiple registries, we found that the incidence of COVID-19 cases among individuals with MS reflects that of the general population. So around the world, we received reports that similar percentages of patients with MS become infected with COVID-19 as the percentage in the general population. There was one study that was done in Britain that included over 5,000 individuals with MS, and no association was found between being treated with an immune suppressing agent for MS, MS disease duration, or degree of disability from MS, and the likelihood of contracting COVID-19. In fact, people who were older or had more disability had actually a lower incidence of COVID-19 than the general population, as did patients who were treated with some of the more potent immune suppressing drugs like infusions or fingolimod. And that may be because those individuals were more likely to self-isolate and to social distance. And as a result of that, probably had less exposures to infected individuals. Next slide, please. So what about if you do contract COVID-19 and you have MS? Are you more likely to suffer severe complications and have to be hospitalized or transferred to the intensive care unit or end up on a ventilator? Well, once again, we received data from multiple registries around the world. And it turns out that the risk factors that lead to a worse outcome of COVID-19 infection in the general population also apply to people with multiple sclerosis. And those risk factors include an older age, being male, and also having underlying medical illnesses such as cardiovascular disease, heart disease, obesity, and chronic lung disease. Now, there was a French study that reported that people who had more disability from MS, and also patients who had progressive forms of MS as opposed to relapsing and remitting MS, were somewhat more likely to have a more severe course of COVID-19 infection. And similar findings were reported by another global registry that involved sites in North America, Europe, and Australia. Once again, finding that increasing disability and a progressive disease course were associated with a higher rate of hospitalization secondary to COVID-19. Many of you may have heard in the news that African American individuals and Hispanic individuals appear to be more vulnerable to complications from COVID-19 than non-Hispanic white individuals. That is true in the general population, while it also turns out to be true in people with MS. So in a North American registry that followed 858 patients, they found that African American or Black MS patients had a threefold higher risk for admission to the intensive care unit or of dying due to COVID-19 compared with non-Hispanic white MS patients. Next slide, please. This is a figure from a paper that just came out in September from one of the registries that I mentioned earlier. And this simply shows that the risk factors associated with a worse outcome from COVID-19 in people with MS include male sex, having cardiac disease or obesity. Also, older people with MS tended to suffer more severe complications, and people who are more disabled neurologically from MS were more likely to be hospitalized or transferred to the intensive care unit. Next slide, please. So what about recovery from COVID-19? You have you've contracted the infection. Are you more or less likely to recover if you have MS? Well, the British study that I mentioned earlier reported that 75% of people with MS who became infected with COVID-19 contacted the registry to let them know that they had recovered or were recovering from the infection. Another source of data regarding recovery from MS comes from the company Hoffmann La Roche. Hoffmann La Roche manufactures the MS drug ocrelizumab, and the company follows all the MS patients who were in the original clinical trials of ocrelizumab, and also receives reports from physicians around the world who are treating MS patients with ocrelizumab about any side effects or complications they may experience. And reviewing the data from Hoffmann La Roche, it turns out that MS patients who contracted COVID-19 during treatment with ocrelizumab, who were followed in their registry, the majority had recovered or were recovering. Next slide, please. The next issue I'd like to address regards the impact of being on a drug that suppresses the immune system to decrease MS relapses on the course of COVID-19 infection. Now, from the poll results that you filled out, a significant percentage of you thought that being on a drug that suppresses the immune system may lead to a worse outcome if you have MS and develop COVID-19 infection. Well, the data on that subject is a bit mixed. So first of all, in a French study that included 347 individuals with MS, they found that most of the severe COVID-19 infections actually occurred in patients who are not on treatment. So that result seemed to be driven by patients who are on some of the self-administered injection therapy, and in particular, beta interferon therapy. So beta interferon therapy includes Avonex, Rebif, Betaseron, and Xtavia. So people who with MS who are on beta interferon therapy actually had a more benign course of COVID-19 infection than untreated patients. That suggests that that drug may actually be protective. Now, they did note that there were some severe cases of COVID that occurred in patients who were on treatment with Teriflunomide, which is Obagio, or rituximab, which is Rituxan, infusion therapy. This signal that people who are on rituximab or related drugs may be at increased risk of severe complications from MS was also suggested in an Italian study in which 784 MS patients were followed. So they found that there was an overrepresentation of MS patients on rituximab or ocrelizumab in the cohort of patients who developed severe complications from COVID-19. And there was an underrepresentation of patients on beta interferon. So what this indicates that if you were on either ocrelizumab or rituximab, these are the B-cell depleting infusion therapies, it was more likely that you would have a severe complication from COVID-19. On the other hand, if you were treated with beta interferon, you were less likely. So that latter finding is consistent with the French study where beta interferon appeared to be protective. They found that patients who were on the B-cell depleting therapies, rituximab or ocrelizumab, had almost a 3 times higher likelihood of severe COVID-19 versus patients who were on dimethyl fumarate or Tecfidera. Yet another study also suggested that treatment, particularly with rituximab, may increase your risk of hospitalization, ICU admission, and mechanical ventilation if you contract COVID-19 infection. So this was a global study of over 1,500 MS patients done around the world. And they found that compared to other drugs, rituximab in particular was associated with higher rates of hospitalization, ICU admission, and mechanical ventilation, but fortunately not death. Ocrelizumab showed similar trends, but of a lesser magnitude. Now, in contrast to that, the data from Hoffman-LaRoche suggests that most people who they followed with MS on ocrelizumab had mild to moderate disease. And as I mentioned earlier, the majority recovered from the infection. So, once again, there's a signal out there that rituximab may increase the risk of severe outcomes from COVID-19, and that has been reflected in two different studies. Ocrelizumab, the data isn't as clear, doesn't appear to be as closely associated as rituximab with bad outcomes. And according to the Hoffman-LaRoche database results, most patients recover and only have mild to moderate disease. Next slide, please. So the last topic I'm going to discuss involves the effects of disease-modifying therapies on responses to vaccination. So this is another question that people with MS often ask me in the clinic. I'm on a therapy that suppresses the immune system. Does that mean I'm going to be less likely to respond to the future COVID-19 vaccine? Am I going to not be as protected as people who are not on a similar type of drug? And the answer to that question is we do not know, because in the ongoing clinical trials of COVID-19 vaccines, people with MS were not included in the subject pool. However, we can make some guesses based on studies that have been done regarding the effect of these drugs on other vaccinations, such as the flu vaccine, such as the measles, mumps, and rubella vaccines, such as the tetanus toxoid vaccine. So there have been a number of studies indicating that people who are treated with beta interferons have normal responses to a number of different vaccines. There's less data on the effect of dimethyl fumarate or Tecfidera on vaccine effectiveness. However, the data that is out there suggests that people who are treated with dimethyl fumarate do have good responses to vaccination. The data on some of the other drugs, including glatiramer acetate or Copaxone, teriflunomide or Obagio, sphingosine 1-phosphate receptors such as fingolimod or Gilenya or Mayzent, and natalizumab or Tysabri, are more mixed. One thing I can tell you is that in most of the studies, patients who were vaccinated on those drugs did mount a protective response following vaccination to the relevant infectious agent. And in some studies, in a study of natalizumab or Tysabri, and in a study of glatiramer acetate or Copaxone, people were found to have normal responses to certain vaccines. On the other hand, there is data suggesting that the responses to vaccination are blunted in patients during treatment with the B-cell depleting infusions such as rituximab. Next slide, please. Oh, I think we missed a slide. Could you go back? Okay. My last slide was just a conclusion slide, and I'll just sum up some of the points that were made during the talk. And those include that overall, the incidence of COVID-19 in people with MS reflects that of the general population. And that includes patients who are treated with immune suppressing drugs or disease modifying therapies. Poor outcomes from COVID-19 infection were associated with the same risk factors as in the general population, including older age, including underlying medical illnesses such as chronic heart, lung, and kidney disease or diabetes, such as male sex. And also African American people with MS were more likely to suffer severe complications than non-Hispanic white people with MS. There were a few studies that indicated that increased disability from MS, as well as people with progressive as opposed to relapsing or remitting MS, were more likely to be hospitalized from COVID-19. With regard to the impact of the immune modulating or suppressive disease modifying therapies, there is an indication that treatment with beta interferon may actually be protective against the disease. This makes sense because beta interferon actually is known to have antiviral properties. However, on the other hand, there's some evidence that treatment with the B-cell depleting infusions, in particular rituximab, may be associated with worse outcomes from COVID-19 infection. The data on ocrelizumab is less clear. There's some conflicting data, but collectively, the data suggests that it imposes less of a risk than rituximab. And lastly, MS patients on certain disease-modifying therapies may have a blunted response to the COVID-19 vaccine, though the data suggests that most people on most of the disease-modifying therapies are likely to respond to the vaccine and gain a degree of protection from COVID-19. The exception might be people treated with rituximab or ocrelizumab. So that's the conclusion of my talk. Thank you for listening. And I will reunite with you after the next series of talks during the Q&A session.
Thank you, Dr. Seagal, for that excellent and timely presentation. At this time, I would like to encourage viewers to go ahead and enter your questions that you may have for Dr. Seagal into the Q&A box, and we will have time at the end of our webinar to address the questions that you have. And next, it will be my great pleasure to introduce Dr. Margaret Hansen. She is our next speaker, and she is our clinical pharmacist. She joined OSU multiple sclerosis team in August of 2019. She received her PharmD from the University of Kansas, go Jayhawks, and completed 2 years of postgraduate residency training. And we are very happy to have her in clinic. Dr. Hansen is wonderful. She meets with our patients who are both newly diagnosed and may be considering a change in medication for multiple sclerosis. She does patient education, and as well, she provides long-term monitoring of labs for safety. She shares that she especially loves her job because she gets to help people better understand their disease process and the medication that they are on for treatment. She is always available for questions and answers. Please help me to welcome Dr. Hansen and her presentation on the therapeutic benefits and risks of disease-modifying therapies, or DMTs as they are known, for multiple sclerosis. Dr. Hansen?
Thank you very much, Kristi, and thank you all for logging in and joining us tonight. I'm very excited to get to speak to you about some of the MS medications, and I hope by the end of this presentation, you feel as though you have a good understanding of some of the risks of the MS medications, but also the crucial role that they play in treating multiple sclerosis. Next, please. So the medications used to treat multiple sclerosis are often referred to as disease-modifying therapies, or DMT, which means that these medications have been proven to decrease MS activity and progression through reducing the frequency and severity of relapses and decreasing the development of new or active lesions on MRI. Growing evidence supports that early and ongoing treatment with a disease-modifying therapy may have long-term benefits of limiting the overall progression of disability over time. Strong consideration should also be given to switching to a highly effective DMT if MS activity breaks through a current treatment. With the addition of highly effective MS medications, we can target a goal of NEDA, or no evidence of disease activity, which generally means no clinical relapses, no progression of disability, and no active new lesions on MRI. In progressive MS, we do of course still want to prevent relapse and new MRI activity, but as these occur much less frequently in progressive MS to begin with, the focus is more on slowing further disability progression. Next, please. So how effective are the MS disease-modifying therapies in controlling MS activity? In the drug studies for relapsing MS, the primary outcome looked at is the reduction of the relapse rate between people taking the study medication versus a placebo or no medication. And in the case of some of the newer MS medications, they're actually compared to some of the older injectable medications or the oral medication Obagio. And what we see is that all of the MS medications that are approved to treat MS have been shown to significantly reduce the relapse rate. This measure is helpful in showing that our MS medications are effective, but we do have to be careful in trying to compare between these results. Because each of these studies is conducted in different patient populations, under different circumstances, and in different time periods. Additionally, all of our MS medications have also been found to reduce new or enhancing lesions on MRI. So overall, we've seen that DMT is effective at modifying MS disease, and that early and ongoing treatment with these medications is our best opportunity to decrease future disability. And we can even target a goal of no evidence of disease activity when using these medications. Next, we'll look more specifically at some of the common and less common side effects possible with these medications. Next, please. So first, looking at the older self-injectable medications, we have the interferons, which most commonly includes Rebif and Avonex. The common side effects are injection site reactions like redness, pain, and swelling at the injection sites, and flu-like symptoms that typically improve over time and can be treated with Tylenol or ibuprofen. Less common side effects may include worsening mood, thyroid abnormalities, or abnormal blood count or liver tests. However, very rarely are these effects actually serious. Next, please. Copaxone and the generic equivalent Glatopa or glatiramer acetate are also self-injectable medications that are very safe to take. Again, the common side effects may be discomfort at the injection site or lipoatrophy, which causes diffids or depressions in the skin. Rotating where the injection is given is very important for decreasing these effects. Up to 15% of people taking Copaxone may experience at some point a reaction soon after injecting the medication that can include shortness of breath, chest pain, fast heart rate, or flushing. This typically goes away within 15 minutes, and while it can be very alarming, it is not heart-related or an allergic reaction. But the unpredictable nature of it makes it hard sometimes for this medication. Overall, though, the older self-injectable medications are very safe to use for MS, but in some cases may be less effective at controlling MS activity for some patients. Next, please. The first family of oral medications is the Tecfidera family, which includes the recent additions of Vomerity, Baffertam, and dimethyl fumarate, which is the generic equivalent of Tecfidera. Most common side effects are GI upset and flushing. These can be improved by taking the medication after eating. The side effects can improve over time, but if you're struggling with GI or flushing side effects with these medications, please talk to your MS provider or myself, and we can help recommend ways for you to optimize how you're taking the medications to reduce side effects. Less common side effects include abnormal liver tests, though any serious injury to the liver is very rare, and low lymphocytes. Lymphocytes are small white blood cells that are part of the immune system. There have been very rare occurrences of PML, a serious infection in the brain, in patients taking Tecfidera, and risk factors identified include older age and low lymphocyte levels for a prolonged period of time, which is why we regularly monitor your blood counts and your lymphocyte levels while you're on this medication. We'll discuss more about PML in a few slides. Next, please. The next family of oral medications is Gilenya, Mayzent, and Zeposia. These medications work by trapping the lymphocytes in the lymph nodes so that they are not available to cross into the brain and spinal cord and carry out an MS attack. So, as expected, we see low lymphocytes on lab results. Gilenya and the related medications Mayzent and Zeposia can increase a person's risk of infection, including upper respiratory infections and urinary tract infections. These medications are highly effective at controlling MS activity and are generally well tolerated and do not have significant GI side effects, though. However, there is more baseline testing before starting these medications, which includes an ECG to look at heart rhythm, an eye exam, and blood work. These medications should not be used in some people who have heart conditions due to the medication causing a decrease in the heart rate when you first start taking it. For Mayzent and Zeposia, the dose is slowly increased over time, over about the course of a week, which limits the effects on the heart rate and rhythm. Again, there have been very rare reports of PML in people taking Gilenya. While there have been no reports of PML for Mayzent or Zeposia, these medications have been on the market for a much shorter period of time, and there may be a potential for a person to develop PML as the medications work in the body very similarly as Gilenya. Next, please. The next oral medication is Obagio. This one gets used a little bit less, possibly because it has the potential for some more serious side effects like causing liver injury, though this is still rare with less than 1% of patients taking Obagio experiencing liver toxicity. It is one of the MS medications that we know can be harmful to a fetus during pregnancy. Both men and women need to take precautions to prevent pregnancy while taking Obagio and after discontinuing the medication. The drug lasts a very long time in the body and can be detected up to 2 years after stopping the medication. So if a man or woman wants to start a family, we need to verify that the drug level is undetectable. And if it's still there, we can use another medication to bind Obagio and clear it faster. Next, please. Tysabri is the first IV infusion medication that we'll discuss. While infusion reactions are possible and listed as a common side effect, many people actually report feeling better after receiving their Tysabri infusion. Patients on this medication may have an increased risk for infection, but most are mild upper respiratory infections. Tysabri is a very effective medication at reducing relapse, inflammation, and MRI activity, and can be a great option for some patients. However, of the MS medications, Tysabri is most associated with PML. So what exactly is PML? It's a rare but very serious infection in the brain caused by the reactivation of the John Cunningham virus, or JC virus, that attacks the cells in the brain that make myelin. PML is life-threatening and can cause significant disability. Damage and inflammation most typically occurs on one side of the brain, and symptoms continue to worsen over the course of a few weeks. Symptoms may be similar to a severe MS relapse and can include changes in vision, speech, cognition, muscle weakness, and clumsiness or poor coordination on one side of the body more often. Effects of PML can be seen on MRI, so it's important to be up to date on recommended MRI monitoring. Risk factors for PML and Tysabri have been identified. First is being previously exposed to the JC virus. Additionally, the duration of time that a person is on Tysabri increases risk of developing PML. And previous treatment with medications that weaken the immune system, like immunosuppressants, increase the risk for PML. In most cases, we will avoid using Tysabri if someone has had previous exposure to the JC virus. The FDA requires a monitoring program known as a REMS program due to the risk of PML, which requires regular monitoring of a person's JC virus antibody status. While PML is very serious and should be taken seriously, Tysabri can be used with very good effect for many patients, and the overall risk of PML with a negative JC virus antibody is very low. Next. Next, we have Aquabus, another infused medication that is given once every 6 months. It is the only medication approved to treat primary progressive MS. In clinical trials, patients with primary progressive MS who were taking Aquabus were found to be 24% less likely to have disability progression at 3 and 6 months compared to people taking a placebo. As we already saw, Aquabus is also a very effective medication at decreasing relapse and MRI activity in relapsing MS. Side effects of Aquabus include infusion reactions like headache, mild fever, chills, tiredness, and muscle aches. These side effects typically improve after the first 1 to 2 infusions, and we have medications available in the infusion site to treat. Aquabus may increase the risk of infections. Most are mild to moderate and include sinusitis, bronchitis, skin infections, and urinary tract infections. Aquabus works by depleting the B lymphocytes, and this can lead to lower antibody levels and decreased response to immunizations. There have been reports of PML in patients taking Aquabus, but the true risk is a little difficult to determine, as some of the patients had also been previously treated with Tysabri. Next. Finally, I will just briefly mention Mavenclad and Lemtrada. Both medications are approved to treat relapsing forms of multiple sclerosis, but are generally reserved for use after a patient has failed some of the other MS medications due to increased risk of adverse effects. Mavenclad can cause low lymphocytes, liver toxicity, and is concerning for a possible increased risk of developing malignancy or cancer. There's another medication this is another medication that is known to cause fetal harm, so both men and women need to use highly effective contraception to prevent pregnancy. Lemtrada is an infused medication, also with an FDA REMS monitoring program that requires monthly lab tests for the duration that someone is on Lemtrada, as well as 4 years after stopping the medication. The medication's label also includes several warnings, including new development of autoimmune disorders, increased risk of stroke, and concern for malignancy. While it may be appropriate for some patients to be on these medications, others are typically tried first. Next. So in summary, I hope from this presentation that you have been able to see that all of the FDA-approved disease-modifying therapies are effective at reducing relapse and MRI activity for patients with relapsing MS, and that early and ongoing treatment with a goal of no evidence of disease activity is our best opportunity to limit future disability. All medications come with risks, and staying up to date with recommended MRI monitoring and lab safety monitoring goes a long way in managing those risks. With 22 approved medications to treat MS, it is now more possible than ever to weigh the risks and benefits of these medications and decide on the medication that is right for you. Thank you very much.
Thank you so much, Dr. Hansen, for that very comprehensive and informative talk. I'm sure that spread some light on all of our multiple DMTs, and I'm sure that many of you have questions. So I would encourage you at this time to go ahead and answer your questions or enter your questions into the Q&A box so that we can address those at the end of the webinar during our Q&A session. So before we move on, let's go ahead and look at another poll question based on what we just heard. You're going to see the poll question. That should be popping up for you. I'm going to go ahead and read the poll question. Overall, I feel that the benefits of my MS medicine outweigh the risks. And if you would enter your answer and remember to submit. And we thank you for participating. Let's see what our pollsters are saying. So it sounds like most of you agree, 76%. Excellent. Thank you so much for participating. And let me move on. It is now my distinct pleasure to introduce Dr. Turisham Gyang. Dr. Turisham Gyang is a neurologist specializing in treating multiple sclerosis, demyelinating diseases, and autoimmune disorders of the central nervous system. At the Ohio State University College of Medicine, she is also the program director of the Multiple Sclerosis Fellowship. She is currently the site principal investigator for MS clinical trials here at OSU Wexner Medical Center. She is collaborating with other disciplines to build multidisciplinary clinics in neurorheumatology and neurosarcoidosis. She believes in providing customized, comprehensive, interdisciplinary care and giving patients the tools they need to thrive and maintain their quality of life. She is a National Multiple Sclerosis Society scholar and a member of the American Academy of Neurology. We are pleased to welcome Dr. Trisham Gyang to our team, and we are so excited that she's here. Dr. Gyang would like to start us thinking about MS drugs with a few poll questions. First question. How many disease-modifying therapies are approved for treating MS? Go ahead and answer, and remember to submit. Thank you so much for participating. And be sure to stay on board so that you can hear the answers at the end of our webinar. So let's see if you can get the next one. How many DMTs are approved for treating primary progressive MS? And don't forget your guess so you can pay attention for Dr. Gyang and tell us the right answer. Okay, last one. When was the first DMT approved for MS? Remember to submit when answering. So it looks like 62% of you had the correct answer. Excellent job. So I can't wait to hear the answer. When do you think the first DMT was approved? Go ahead and press submit. See what your guesses are here. And it looks like everybody was on track. 64% got it right at 1993. That's what you all think. Okay. Well, I can't wait to hear what the actual answers are. So let's go to our next presentation. Join me in welcoming Dr. Gyang and her presentation, Newest Disease-Modifying Therapies Recently Approved and on the Horizon. Dr. Gyang.
Thank you very much, Kristi. I'm very excited to be talking to all of you this evening. As Kristi mentioned, I just started here at OSU, and I'm very excited about a lot of the programs, and I'm excited to be part of the team. I will be talking today about the newly approved disease-modifying therapies, and I'll also be talking about some therapies that are still in research, and I will talk to you about some of the research that we're doing here at OSU that is going to be very exciting. Next slide, please. So to answer one of the poll questions, we now have 22 disease-modifying therapies for MS. Now that has come a very long way. So there's 22 different options if you have MS and you're considering a medication. And these medications come in a variety of formulations. So there are pills, there are injections, there are infusions. The medications come in different formulations and that can be adapted to different people. Now, most of these drugs are approved for relapsing remitting MS. So relapsing remitting MS is the more common type of MS where people have relapses or acute symptoms, and then those symptoms get better or go away. So most of these drugs are approved for relapsing remitting MS. Within the last few years, the term active secondary progressive MS became used a lot, and the FDA actually approved a few drugs for what's called active secondary progressive MS. And basically what that means is in patients with secondary progressive MS, meaning there's a patient that started out as a relapsing remitting patient and then gets into a point where they're slowly having that continual progression without improvement. If they still have relapses, or if we can still pick up new MRI lesions, during that phase, that's what's termed as active secondary progressive MS. Now for primary progressive MS, unfortunately, we only have one drug, and the name of that drug is ocrelizumab or Ocrevus. Now this is the only approved drug for primary progressive MS. There have been a lot of drugs that have been studied for primary progressive MS, and unfortunately, a lot of them have not shown good results, and ocrelizumab is the only one that has been approved. I will be talking later about some clinical trials that we're doing in progressive MS that could be very exciting for patients that have this type of MS. Next slide, please. Okay, so this is a timeline, and I'm not going to go through all the details on the timeline. And then to answer this, another question on the poll, when was the first drug approved for MS? 1993. So one of the interferon beta drugs was approved in 1993. So that was not too long ago. That was about 27 years ago. But since then, between 1993 and this timeline goes on to 2018, we've had a lot of drugs that have been approved for MS. And I'm just showing this to tell you there's been a lot of research in MS. There's a lot of new things coming out. And the researchers in MS have been working very hard. So just to go briefly through the timeline, and we're focusing on the upper part of the timeline, which is the FDA approval. Initially, we had the beta interferons and glatiramer acetate, which would be Copaxone. So we're thinking things like Rebif, Avonex, Copaxone. And then mitoxantrone was approved in 2000. It's not commonly used these days. And then we have natalizumab or Tysabri, which has been, which was a great inclusion to the MS drugs that, we had at that time. And then subsequently, we had a variety of other medications. We have fingolimod or Gilenya, teriflunomide or Obagio, dimethyl fumarate, also known as Tecfidera. We have Lemtrada, the alemtuzumab, which is also known as Lemtrada. And then the Clizumab was approved around 2016, but it has been taken off of the market for MS due to a lot of complications that came from it. And then around 2017, ocrelizumab was approved for both relapsing types of MS and primary progressive MS. And in the next slide, we're going to talk about the newer drugs that have come out since 2018. Next slide, please. Okay, so this is just a broad categorization of the drugs that we have. So we have injections. In the middle, we have pills or oral drugs that you take by mouth, and then we have infusions. On the injection section, the big categories or the big groups are glatiramer acetate, so Copaxone, and then Glatopa. Those are all formulations of glatiramer acetate, and then interferon beta, Rebif, Avonex, Plegridy. There's a variety of formulations of the interferon beta in the interferon beta group. And then for the oral drugs, for the longest time, we had three main oral drugs, fingolimod or Gilenya, and then this is Tecfidera, which is known as dimethyl fumarate, and teriflunomide or Obagio. And then for the infusions, you can see a list of infusions that we have that are available right now. More recently, we've had a few new drugs that have been added to this profile, and I will be talking about the new drugs. So in terms of injections, there has been one new injection that was approved very recently, known as Offertunamad. The trade name is Kesimpta, and I'll be talking about that. And then we've had a variety of oral medications that have also been approved within the last 2 to 3 years. And we'll be talking a little bit about each of them to figure out who's the best patient to take them and who should not be taking them. Next slide, please. So we're starting with the most recently approved, Offertunamab or Kesimpta. It was approved in August 2020, so just a few months ago. And it's approved for the relapsing types of MS, and active secondary progressive MS. Now, CIS is a term that we use for very early MS. So in patients that have had that first attack of MS, but don't quite meet that criteria for MS yet, but all other indications show that they have MS, sometimes we use the term clinically isolated syndrome. So this drug is approved for both the early types of MS, which is CIS, and relapsing remitting, and the active secondary progressive. Now, how does the drug work? So it works very similar to ocrelizumab or Ocrevus. It suppresses the B lymphocytes. So, the B lymphocytes are part of the immune cells that we have in circulation, and this drug specifically targets the B lymphocytes. In clinical trials, it had about a 50 to 60% reduction in relapse rates when it was compared to Obagio. And this is taken as an injection. So this is a little bit different from, the other B cell suppressant drugs we have, like ocrelizumab or rituximab, that are taken as infusions. This drug is an injection that you can self-administer, basically. And it starts as a weekly injection, but then advances to a monthly injection. So those injections come on a monthly basis once you have completed, I think it's 4 weeks of a weekly injection. And then who are the patients that probably should not take this drug? So in terms of the B cell depleters, patients that have had, or the patients that have active hepatitis B infection should not be taking these drugs. And before we start medications like this, like Kesimpta or other similar drugs, we usually get a panel of tests to make sure the individual does not have hepatitis. We look specifically at hepatitis B and hepatitis C. And we also have other tests that we look at, like tuberculosis. With some drugs, we get the chicken pox titer to see if they are immune. But in specific with this one, we want to think about hepatitis B. If there's an active hepatitis B infection going on, then this drug should not be given. Next slide, please. So the second drug I'm talking about is Ozanimode, also known as Zeposia. This was approved in March of this year, so not too long ago. And similar to the drug, the Offertunamad, it's also approved for both relapsing types of MS and the secondary progressive MS, but that secondary progressive MS have to have activity or relapses during that secondary progressive phase. How does this drug work? So we want to think about this drug very similar in action to Gilenya or Fingolimod. So what it does is that it captures your lymphocytes within lymph nodes. So the lymphocytes are in a way locked up in the lymph nodes and are not out in the circulation where they can get into the brain or get into the spinal cord to cause relapses. In clinical trial, it reduced relapse rates by about 40%, and it was compared to an interferon beta. This is a pill, and this pill is taken once a day. And then just thinking about who should not be taking this drug. So medications like this, or that work similar to Gilenya, patients with a recent heart attack or recent stroke within the last 6 months, this is not the best drug, for individuals that have had a recent heart attack or stroke. Patients that have sleep apnea, or they are very specific heart conditions, and a lot of those heart conditions have to do with heart rhythm, a dysfunctional heart rhythm, should not be taking this drug. And then there's a lot of drug interactions with very specific antidepressant medications. And so you want to make sure you let your doctor know all the medications that you're on so that we know if there's a potential interaction with one of these medications. Next slide, please. The next drug we're talking about is Mayzent or Siponimod. Now, this was approved about a year, 2019, so March of last year. Works very similar to Gilenya or Fingolimod, so in the same category. And as we said, it locks up those lymphocytes in the lymph nodes so that they're not out there causing damage to cause MS. This is a pill that's taken once a day, And, similar to the previous drug, patients with a recent heart attack or stroke should not be taking this drug. Patients with certain types of heart diseases should not be taking this drug. And I think with this one in specific, there's an enzyme test that is done because some people don't metabolize this drug adequately, and we have to test for a specific enzyme before this drug is given. There's a host of other tests, like an eye test that is usually done before this drug is started, and also your titer for the chickenpox infection, or the immune status for chickenpox has to be tested as well. Next slide, please. So the next drug is Cladra Bean, or Mavenclad, and this is quite of a different type of drug because it's given in a way that we call an induction method. It was approved in the US in March of 2019, but it had been approved in Europe and in Canada years before it was approved here. This drug is given to, it suppresses the lymphocytes, both the B and the T lymphocytes. And the way that it's given is very unique. So it's given in 2 yearly courses. So in the first year, you get one course that takes 2 weeks, and that's it. And then the second year, you get the second course that's given for 2 weeks, and that's it. So you're not taking a medication every day. You're just taking these, 2 weeks of, pills in the first year and the second year. And the idea is that we're trying to reset or reboot your immunity so that your immune cells are not causing inflammation in terms of, inflammation in the brain or the spinal cord that we see in MS. Who should not take this drug? First of all, women that are pregnant or women that are breastfeeding should not be taking this drug. And individuals with cancer or this specific infections, serious infections that, you should not take this drug if you have. And just like with the other medications, we test for a host of different silent infections or latent infections before we administer this drug. Next slide, please. And then finally, we have 2 different drugs that I put together, and I put them together because they work very similarly. We have Vomerity and Berfertam that, they were both recently approved. They work very similar to Tecfidera, and Tecfidera has been out for many years. So these drugs work very similarly. They're both pills. These are pills that are taken twice a day. They may increase infection risk, as we heard from our previous discussion. The one thing with Vomerity, or the drug on the left hand, is that it may have less gastrointestinal side effects than Gilenya. Now, people on Gilenya know that sometimes there's that risk for GI or gastrointestinal side effects. Possibly Vomerity may have a less effect on the GI system. So that's one advantage of it. Next slide, please. Okay, now we're changing gears a little bit. We're talking about drugs under investigation. So what are the drugs that are being currently studied for MS? And I have a few drugs that I'm going to talk about. The first group of drugs would be the BTKI drugs, or the Bruton's tyrosine kinase inhibitors. There's a variety of these drugs that are being studied. And the interesting thing is that we're studying these drugs both for relapsing types of MS and for progressive types of MS. As we said, we just have one approved drug for primary progressive MS. So there's a lot of need, for a new drug for primary progressive MS. So we do have these drugs that are being tried right now. Some preliminary studies have shown some promise, but more studies are needed. Phase 3 studies are currently going on. And OSU is actually going to be taking part in some of these studies. We're getting ready to, start enrolling for some of these studies. And, this is something that's potentially going to be a very big deal if this is something that's effective, especially for progressive types of MS. And then we have other groups of drugs, the tyrosine kinase inhibitor drugs that, currently are also being looked at for progressive MS phenotypes. So we have masitinib that's currently also in phase 3 trials, and this is primarily looking at progressive types of MS. Now we have oblituzumab, which is very similar to ocrelizumab and works on depleting B cells. This is another drug that's being studied, and we're probably going to find out very soon if this is effective. Next slide, please. And a few other drugs. The first one on this slide is Ibudilast. So Ibudilast has been studied for neuroprotective effects, meaning can this help to protect the brain and just preserve the brain volume? There was a phase 2 study that was recently published that showed positive data that this drug helped to slow down the loss of brain volume in patients with MS. So, more studies are underway, I'm sure, because we need more studies before it gets to a point that it's going to be approved. But this was looked at as a potential add-on therapy. So it's something that you could take as an add-on therapy to the disease-modifying drug that you're on, and it may help to lessen some of that volume loss that we see on the brain scans when we look at patients with MS. There's another drug, Offertunamad or anti-lingo. So this drug was looked at to see if it would help with myelin repair, meaning how can we fix the damage that has already been done? So a lot of the drugs that we use today help to prevent future relapses or future spots of inflammation. But then how do we fix the problem that has happened already? So this drug was looked at. The most recent study was not very promising, meaning the results were not positive, but there is still some plans to look at it to see if there's any role it could play in helping with repairing the damage that has been done in myelin. And then finally, we have a vitamin, biotin. So high dose biotin has been studied in progressive MS. There's a lot of mixed data, meaning some studies show promise and some studies don't. In a recent study, it didn't really show improvement in slowing disability, but this is still something that is still up for investigation or up for review. And this is something that's a vitamin that's easily taken, and it's not going to be very harmful, but potentially may be helpful. Next slide, please. So I think this is the last slide. I just wanted to put a slide up about stopping or switching disease-modifying therapies, because sometimes when we talk about a new drug that just came out, people want to know, should I stop what I'm on and go on a new drug? Is there a role, is one of the new drugs going to be better than what I'm taking now? I always tell patients, you have to talk about this with your doctor. You should never stop your medication abruptly, but have a discussion with your doctor. And what are the common reasons to stop a disease-modifying therapy? So if the disease-modifying therapy you're on now is not working, meaning if you're having relapses while you're on it, or if you're having new MRI lesions. So even if you don't have relapses, if we do those interval MRI scans and you're having new lesions, that may be a reason to change to a different medication. If you have side effects, meaning you're not tolerating the medication that you're on. And Dr. Hansen talked to us about the different side effects that could come from different drugs. Sometimes it becomes a problem with either keeping the drug down, or you're having a lot of maybe infusion reactions, or you're not just tolerating a drug well. There may be a discussion about switching to a different drug that you would tolerate better. Sometimes it's an issue with safety. So if we're concerned about, for instance, PML, if you switch from being JC negative to being JC positive, there's a concern that your risk for PML would be higher. Or if there's other safety concerns, if all of a sudden you're diagnosed with cancer, we talked about some of the drugs being drugs that should not be taken by people that have cancer. So if there's a safety concern, sometimes that's a reason to stop a disease-modifying therapy or to switch to a different treatment that is safer. And then the last point is pregnancy. So, you know, a lot of MS patients are young women that want to start families. And we always want you to be able to, you know, build your family if that's what you want to do. But not all the medications can be taken during pregnancy. So we always have that discussion with you up front. You know, if there is a plan for pregnancy, we always want to be involved in that discussion to know when to stop the medication, you know, and when to resume the medication. And pregnancy also includes breastfeeding, because there's some of the drugs that we, you know, we don't want to keep giving that drug while you're breastfeeding. So these are some of the reasons why a medication is switched. In general, you know, the fact that a new medication is out doesn't necessarily mean we should switch from one drug to another, but have a discussion with your doctor and, you know, come up with a good plan for, you know, whether what you're on now is working or not, or whether you need to switch to a different drug. I think this is the last slide. Next slide. Let's see if there's another. Okay, yeah, we just have the references, and I think there's a thank you slide on the last one. So if you have any questions, as we all said, we will be available to answer at the end. And I'm turning this back to Kristi.
Dr. Guiyang, thank you for such an enlightening and hopeful talk regarding DMTs that may be available in the near future. So we've reached the point in the evening that we are going to start our question and answer session. So I would like everyone to go ahead and submit your questions, put those into the Q&A box. And I'm going to invite back our wonderful 3 speakers that have already given presentations tonight. And I would like to introduce the other members of our panel who many of you know. First is Dr. Robert Follis. He is a neurologist and he specializes in taking care of patients with multiple sclerosis, demyelinating diseases of the brain and spinal cord, as well as autoimmune diseases of the brain and spinal cord. Dr. Follis has been involved in lots of clinical research in MS, and I know many of you know him personally from clinic. In addition, we have joining us this evening is Grace Schaffner, and she is a physical therapist, and she has been a physical therapist since 2014. And the majority of this time, she has been working with patients with neurologic conditions. She is our outpatient rehab multiple sclerosis program coordinator. And she has special interest in multiple sclerosis, vestibular conditions, and community fitness. So throughout the last hour, many of you have participated. I see lots of questions up there, and you have been submitting those. So Dr. Seagal is going to rejoin us, and he will be leading our question and answer this evening. Dr. Seagal, what's our first question?
Thank you, Kristi. Well, the first question goes to Grace Schaffner, and that is, could you discuss the role of physical therapy in MS? And in particular, are there physical therapists who are specialized in the treatment of MS? And what do we have to offer in that realm at The Ohio State University?
Yeah, absolutely. Thanks for that question. For physical therapy with MS, we treat many conditions that are related to MS. So there can be a lot of different impacts on mobility, or some patients with MS may have difficulties with dizziness or bowel and bladder issues as well, which is a less common known thing that physical therapists can treat with a pelvic floor physical therapy specialization. So we, in physical therapy, may work on gait training or reteaching you how to walk, working on strengthening of your muscles, different balance interventions, and along with treating many other symptoms that may present along with your MS. We can also specialize in assisting to develop an exercise program for you to follow. Many patients with MS may have more trouble with fatigue or heat sensitivity, and we can provide different advice for you on how to manage those symptoms along with staying active and healthy throughout your life. And those things can help you to keep your mobility for a longer period of time. Additionally, we can help if you do have more trouble with mobility and maybe you need an assistive device or perhaps a wheelchair, different aids to help with mobility, we can help recommend devices for those as well. We do have a team of physical therapists across several of our departments here for different neurophysical therapy clinics who we specialize in working with patients with MS, and we meet regularly to discuss updates and different treatments that we can offer to patients with MS.
Thank you very much. Now, I've received a number of questions about Ocrevus during the pandemic, and those questions include, if you're on Ocrevus, should you delay an infusion until the pandemic dies down, or should you continue on Ocrevus and just maintain social distancing measures and self-isolation in order to reduce the risk of exposure? Another question related to Ocrevus is, should you take a break from Ocrevus infusions in order to get the vaccine? And implicit to all of these questions is, if you do interrupt Ocrevus treatment, how long a period of time should transpire in order for your B cells to come back, counts to come back, in order to get the vaccine? So let me direct those questions first to Dr. Follis.
Well, those are both good questions, questions that we have to answer every day. So in general, as Dr. Seagal mentioned earlier, the safety profile for Ocrevus in the midst of a COVID pandemic is really not bad. In some cases, it seems to actually lessen disease severity. The bigger question, though, revolves around what to do about a vaccination. As Dr. Seagal presented data earlier, your ability to robustly mount a good response to vaccine may not be what it should be if you're on Ocrevus. So in that case, you will, if you want to be vaccinated, the answer will be you'll have to let your immune system recover to a point where you can adequately vaccinate to a COVID vaccine.
So in general, Ocrevus infusions are given every 6 months, but most people's B cell counts may not be back to a normal range at the 6-month time point. So let me ask Dr. Yang, what do you think you're going to be recommending for patients with Ocrevus once the vaccine becomes available?
I think for patients on Ocrevus, from what we've seen, sometimes that B cell remains suppressed for many months, even after we stop Ocrevus. So in general, we give it every 6 months, but just based on, anecdotal data from patients that I've seen that have stopped, sometimes that B cell can be suppressed for up to a year. Now with patients that take the flu vaccine on a yearly basis, we still recommend patients on Ocrevus to take the flu vaccination. In general, sometimes you could have a bit of a separation between that vaccination and the time they get the infusion. We typically would say 4 to 6 weeks. But, a lot of times, if we want to wait for those B cells to get back to normal, we may wait up to a year before that happens. And so I think it'll come to finding a balance, or a point where maybe towards that middle part of the cycle, several weeks or several months in the middle of the infusion or an infusion cycle, we could consider doing a vaccination. Or if we want to take the route of waiting for those B cells to come back, that's a little bit unpredictable, and the wait may be a lot longer than we expect if a patient has been on Ocrevus for a long time.
Right. So, I mean, in general, when people with Ocrevus or another infusion are going to get vaccinated, if we're not going to stop the medication, I usually recommend waiting to get vaccinated 4 to 6 weeks before the next infusion. It usually takes vaccines that long to have maximal effect. And with some of these COVID-19 vaccines are going to be 2 shots separated by a time period. So, there's always this balance between wanting to wait for the immune system to recover in order to get an optimal response to the vaccine, but then you may be at risk for a relapse as the B cells or other immune cells recover. So I don't think there's one answer, but one strategy may be that we have ways of tracking your immune cells in the blood with tests, and so you could periodically measure the immune response and wait to a certain time, maybe not 8 months after the last infusion, 6 months, 8 months after the last infusion, and when the immune system begins to recover, administer the vaccine then. I'm wondering if Kristi or Margaret have any remarks regarding this to add?
So I have been discussing with some of my patients who are on Ocrevus the possibility, as you mentioned, of testing for the actual B cell population somewhere in between 6 and 9 months by drawing a lab called immunophenotyping, in which we can see what the actual number of B cells is to plan for vaccination. That's one solution that I have been discussing with some patients in regard to vaccination planning. Margaret?
I would agree. I think if you're going to be delaying the next infusion, that we will need to do some B cell tracking to see when people are starting to have their B cells come back, and kind of deciding at what point we think they can respond adequately to a vaccine.
Okay, thank you. And one thing that we're going to discuss as a group is whether we could perform a study to measure people's response to the vaccine when they're on these different medications. So that may be a study we're going to do in the future. Here's a question that I'm going to first address to Dr. Follis and then open it up to the round table. This question is as follows. If you had to pick which one recent advancement makes you most optimistic for the future of MS treatment? Dr. Follis?
Well, that is an interesting question. I often ask the residents and students myself that very question. Do you think that the big advance are the effective medications for the treatment of MS, or do you think the big advance is MRI? Because with MRI, we can diagnose the disease much earlier, but if we didn't have the medications available, they couldn't be treated. If we didn't have MRI, we would have to wait later to treat. So it's a match made in heaven, and the advance is MRI plus effective therapy. It's totally changed the landscape. Very, very hopeful and promising outlook, and allows us as neurologists to diagnose this disease very, very early on and start really effective treatment right away, which is so important.
Okay, let me ask Dr. Yang, same question.
I think the one thing, if I would pick one thing, I would pick new therapies for progressive MS, because that's been a big lack. We have a lot of good therapies for relapsing types of MS, but I think the progressive MS has lagged behind. So whether it's some kind of a neuroprotective drug or remyelination, or just something that stops that slow progression that we see happening, and a lot of times we don't have a lot of tools, we don't have a lot of options for mitigating that. So if I were to pick one, I'll pick something for progressive MS types, whether it's secondary progressive or primary progressive MS.
Okay, thank you. Kristi Epstein?
So I would just like to weigh in and say that one of the most exciting things, I think, is some of the research that's happening such as the research in your lab, Dr. Seagal, and patients may be able to, hear about some of the exciting things that you've been doing in your lab in terms of new therapy and identifying problems and solutions in multiple sclerosis. So I think always looking to the field of new research that's happening is one of the most exciting things that is really starting to ramp up in multiple sclerosis.
Thank you, Kristi. That's very kind of you to say. And we are very excited. One of our latest studies has shown ways in which the immune system may be manipulated to actually stimulate repair. And that may be applicable to MS, and we're looking into that. So, Margaret Hansen.
Well, as a pharmacist, I have to say drugs, right? So definitely excited about new medications, opening up what could be good therapies for progressive MS. The BTKIs are particularly interesting. And then I'm going to kind of echo Kristi that I think Dr. Seagal joining here and the plans to grow the OSU neurology department and the MS team is very excited, and I'm very happy to work with this team.
Well, we're very excited to work with you too. I just have to say that Margaret has brought her expertise to our clinics and counsels patients individually, and she's really enhanced the care we give. And in addition of Kristi as well, she's been a huge advocate for MS patients and a great clinician. So I'm going to also direct that question to Grace Schaffner.
Yeah, I think one of the biggest things that I'm most excited about from a rehab perspective is all of the new research and just ideas surrounding early intervention in general for the MS population. So I think that's so crucial, even from what we do from a rehabilitation perspective. I think from the medical perspective, getting involved early obviously has great benefits, but then from the rehabilitation side as well, the earlier we can get involved and maybe help prevent some things from a mobility standpoint and make recommendations early. I think that's one of the biggest things that I'm excited about from our perspective in rehab.
Okay, thank you. Well, unfortunately, we don't have time for more questions, though we will be able to answer the questions, I believe, through a posting. But now I will turn back to Kristi.
Okay, first of all, I would like to thank all of our speakers, and I would like to thank everyone for participating in this evening's event. We were very excited to have you. And I would like to let you know that your questions that were unanswered in the question and answer chat box will be answered on the website, and these will be answered by our providers. And I would like to invite you to log on to www.wexnermedical.osu.edu/MS-community. And there you can learn about updates to our MS program, including details about not only this presentation, but our future sessions in our virtual education series. So the doctors will be answering the questions, as I said, that we didn't have time to get to in our Q&A session tonight. We will post those answers on that webpage in the coming days. So please be sure to check it out. And again, I would like to thank everyone who participated and everyone who joined us this evening. And we are so looking forward to seeing you at our next event. Good night, and thank you.